My name is Morgan Grafe, and I'm reviewing my findings from the article The Role of the Family in the Course and Treatment of Bipolar Disorder by David J. Miklowitz. All of my facts and opinions are based off this article. Reading the article, I learned that there are two types of bipolar disorder, bipolar 1 and bipolar 2. Bipolar 1 is where an individual has at least one episode of mania or a mixed disorder, and bipolar 2 is where an individual experiences more episodes of hypomania alternating with severe periods of depression. Bipolar disorder is highly recurrent. 60% of patients experience recurrences of mania or depression within 2 years, 75% within 5. Up to 15% die of suicide and 50% attempt. Miklowitz wrote the article to describe how family therapy or family education helps patients with bipolar disorder. He describes two types of families: high expressed emotions, or EE, and low EE families. High EE families react to their children with frustration, criticism, hostility, guilt, or anxiety. Research has found that high EE families contribute to the relapses or causes of the disorder. High EE families contribute to symptoms of BD to be the symptoms of BD to be controllable, meaning the person has a control over what they are doing. Low EE families understand the uncontrollable factors of the disorder. In order to assess high-risk adolescents, families' intervention should consider the biological and psychological vulnerabilities of their parents and the environment. When looking at a patient, one should understand the family dynamic and how they individually handle criticism or negative situations. Within the article, there are a few experiments that are discussed. One particular experiment where J.M. Hooley, S.A. Gruber, L.A. Scott, J.B. Hiller, and D.A. Yerglund-Todd in 2005 examined the neural activation in college students with or without a history of depression. The experiment consisted of tapes where mothers criticized, praised, or held neutral comments, and throughout the experiment, the students listened to the tapes, and within the patients that had a history of depression, their prefrontal cortex, which is a part of the brain that plays a major role in memory, problem solving, expression, interpersonal skills, and behaviors, they did not respond. And then with the students that do have vulnerabilities, the prefrontal cortex responded. The study concluded that the vulnerabilities can contribute to emotional distress and contribute to unregulated moods through the fact that students that are used to criticism or don't know how to deal with negative conflicts hold the emotions inside. Miklowitz describes two trials that were conducted of family therapy that involved 101 patients that suffered from bipolar disorder. The average age of the patients were 36 years old, and to qualify for the trials, a patient must have had a manic episode 3 months before the trial began. Out of the 101 patients, 82 of them began the trial from a hospital. Each patient was randomly assigned to two different treatment plans. One of the plans consisted of family functional therapy alongside medication, and the other consisted of two sessions of family education, crisis intervention as needed over 9 months, and medications. Within the 2-year follow-up, the patients who participated in FFT were more likely, or family functional therapy, were more likely to not relapse into a bipolar episode. The second trial compared FFT and medication to an individual psychoeducational therapy of similar duration and intensity over 9 months, which included taking medications. Over 2 to 3 years, patients in FFT had longer periods of stability. Psychoeducational therapy is also individual therapy. After 1 to 2 years of treatment ending, 12% of the FFT patients were hospitalized compared to the 60% of the patients that participated in individual therapy. The Systematic Treatment Enhancement Program, or STEP for bipolar disorder, looked at the difference between FFT and other therapeutic methods. Patients that showed minimal signs of depression were assigned randomly to one of 3 intensive therapies with medications. One of the 3 were FFT and interpersonal and social rhythm therapy. Social rhythm therapy focuses on the daily routine and individual problem solving, or cognitive behavioral therapy, or which is also called CBT. Each consisted of 30 sessions, to a minimum of 3, and then they compared it to a minimum of 3 sessions of collaborative care, or CC, psychoeducation and medication. Over a 1-year period, all 3 of the intensive therapies had a faster recovery rate of 169 days. Mickiewicz concurs that family chaos and stress strongly contribute to bipolar episodes. The 2 trials concluded that FFT, or a combination of FFT and CBT, helps stabilize patients who are adolescents and school-aged children, making communities aware and teaching communication, problem solving, and self-regulation to at-risk children and their parents, help reduce the chances of a full set manic episodes and reduce the high E in the family setting, not acting. All in all, I believe that the evidence shows that family support and education is helpful to the children and families that suffer from bipolar disorder.